So everyone heard me harping about inflammation as being a big part of the atherosclerotic process and how we can treat and modify these plaques. We can do everything we want to treat blockages, but if we don't treat the underlying cause for why people come back to the cath lab, why you have to come back for a recurrent stent, why you have to come back because your bypass failed, then we're not really approaching a good outcome for our patients. This is one of the studies that we've been very fortunate to have at the heart hospital that has a very limited site access, and some of the things that we're looking at are very revolutionary. They're things that a lot of people don't look at anymore when they do their trials. So the name of the trial is the DANCE trial. I have no disclosures to the talk. There were 36 sites in the United States that were chosen to do this. We enrolled over 100 patients in one arm, 100 patients in the other arm, and we finally have the one-year data. DANCE stands for Dexamethasone delivered to the Adventitia to enhance clinical efficacy. And the Adventitia, when you look at the artery, the composition of the artery, the intima is the inner lining, the media is the muscular portion, and the Adventitia is what holds the artery and has a lot of the inflammatory response cells. So the study was an open label, single arm trial, and it looked at patency either by ultrasound or by clinically driven TLR, target lesion revascularization. That means that the patient had to come back to the cath lab because they were having symptoms. It also looked at the safety of the device and of using the medication through the device. The patients that we enrolled were patients that had either cramping in their legs at moderate to severe distances, as well as patients that had pain in their legs at rest. The lesions that we selected were either in the thigh or just under the knee. And again, the lesions were less than 15 centimeters. And after they got whatever treatment was chosen, they were then treated if your intervention was successful. So you had to have done your intervention, and then you were happy with your results, and then we enrolled you in the trial to use the dexamethasone. So we were able to do 130 with just plain old balloon angioplasty. We were able to use 155 with atherectomy. It didn't matter what atherectomy we used. You had to use some form of atherectomy. After they were then treated, we then were able to give the dexamethasone. There was blood drawn at the start of the case. There was blood drawn 24 hours after the procedure, and then there was a 1-month blood draw after the procedure. We followed up these patients both based on their symptoms as well as with ultrasound at 6 months, 12 months, and the plan is to follow them up to 2 years. There was good follow-up in the enrollment. We enrolled 100 patients from November 2014 to January 2015. We were able to keep track of 73 of these patients. What we used to deliver the dexamethasone is a brainchild of a MIT grad. If you look at the artery that is made up of the lumen, the media, the adventitia, he was able to put a needle, a 32 gauge needle inside a balloon, and when the balloon is inflated, then it allows the needle to advance into the adventitia, and then we're able to deliver whatever drug was chosen to deliver it to the adventitia. For this study, we used dexamethasone. Basically, it's limitless, whatever you want to give through that. If you want to give some of the neoplastic drugs, if you want to give stem cells, it doesn't matter what you want to deliver, we're able to deliver it at the adventitia. So this is the device at work. You'll see the balloon opens up and the needle is advanced, and the needle goes into the adventitia, and then we inject the medication, and it surrounds the vessel, and it also longitudinally goes down the vessel. So we're able to deliver the drug circumferentially and longitudinally. So doing that along all the segments of the vessel of the lesion length, we're able to treat the entire lesion with the anti-inflammatory medication. This is the angiogram of what it looks like while we're injecting. You see the balloon go up, we inject dexamethasone mixed with contrast, and you see that we're staining the entire artery. Normally when you see this in a post-angioplasty result, it's not what you want to see. You don't want to see staining outside the artery. In this case, we wanted to see staining outside the artery because we know that we're delivering the drug. This is something that is not seen with our current drug-coated balloons. We don't know how far and how deep into the Adventitia the drug gets. There's nothing to tell us how much drug is being delivered. So what we normally will do is we'll treat atherectomy, like we did this morning. We remove the plaque. We treat whatever we need to remove the plaque. When we do that, there's an inflammatory process that occurs in the Adventitia. The recruitment of monocytes, macrophages. That injury then leads to cytokine expression. And once you have cytokine expression, you then have recruitment of further cells to try to quell propagate the inflammatory process. This then is what leads to neointimal hyperplasia or proliferative hyperplasia, which is where you start having lumen loss, and what you have is restenosis. So whatever work Dr. Rollison or Dr. Mago did 6 months, 12 months down the road, it comes back narrowed up again, and you have to be treated again. So how do we stop this? We stop it by giving dexamethasone right at the inflammatory process, right up front. You prevent everything by treating it upstream. So after you cause your injury, you basically, once you start the fire, if you don't leave the fire is going to spread and it's going to get out of hand. By using dexamethasone, you're able to quench the fire. You're able to quench the inflammatory process and therefore try to prevent the restenosis. So does it really work, or is it just hocus pocus? So the dance trial was pretty significant in some of the things that we looked at, as far as the male ratio was 50% male-female. Most peripheral studies tend to be 3/4 male. African American population tends to be harder to treat, and there was a higher number of African Americans in the study. We also treated overweight patients, obese patients, and the CRP marker, which is an inflammatory marker, was not active at the time prior to enrollment in the study. The lesions that we treated, Rutherford 3, are patients that have claudication with moderate exertion or mild exertion. We also had 1/4 of the patients had severe calcification. When you looked at the lesion itself, that's how we classified them. That task score tells you what the morphology of the lesion is. Type D is the worst. Type C and B are better. You see that most of ours were B and C. We also see that stent utilization was about 1/3. But when we look at the characteristics of the study, they compared differently to some of the other drug-coated balloon angioplasty studies. When we looked at the safety of the device, we didn't have any complications of the device. We didn't have any complications after giving the dexamethasone. We actually had some patients that felt better in their knees after we treated their popliteal with the dexamethasone. We also had no deaths. And again, how well did it work? At 1 year, we had 85% patency. That means at 1 year, the vessel still had less than 50% residual stenosis. At 1 year, you had only 8% of patients, 8 out of 100, complaining of some type of symptom that they required another intervention. So very good results. How did this compare to some of the other results that we've seen for other studies? So when you look at the atherectomy arm, the patency is less. The patency at 1 year for an atherectomy arm is about 78%. The patency using right now our current drug delivery system, drug-coated balloons, we see that they're close to being, the impact was 82%. One of the other companies was 65%. The difference is that they excluded calcium. The dance trial enrolled 3 times as much patients with severe calcification as the drug-coated balloon trials. They also treated more popliteal lesions. They treated more difficult lesions. If you notice, in the drug-coated balloon arms, they treated mostly task A, which are very simple lesions, very short lesions, whereas the dance trial treated much more difficult lesions. When you looked at the long-term outcomes at 1 year, immediately at 4 weeks, patients complained. Patients said there's an improvement in how far they can walk and any pain when they walk. This was extended out to a year, so the results were very lasting. They were lasting up to a year. The novelty of this study, and what excites us as cardiologists and interventionalists and peripheralists, is that we were actually able to measure biomarkers. So we measured CRP, which was a response to inflammation. And we've seen that when the CRP elevates, this often leads to restenosis. So we were able to compare an arm and dance partner where we took patients that we treated with atherectomy or balloon and treated with no dexamethasone and compared those to we treated the same treatment except we gave the dexamethasone in the artery. And we see that in the people that didn't get dexamethasone, you had a 500-time increase in the inflammatory response. Whereas the patients that got the dexamethasone locally, they had no increase in their CRP levels. When you look at some of the proteins that also cause stimulation of inflammation, they go out and recruit cells to come and treat the site of injury, we saw that dexamethasone also decreases those levels. So all the markers that we see that we can measure that are causing inflammation, we're seeing all of those markers being sequestered just by giving dexamethasone locally in the area of the artery, not systemically. So we're able to use Bullfrog to deliver dexamethasone after we treat the vessel to prevent the restenosis cascade. We were able to follow up these patients at 1 year and still have good patency and low revascularization. We also were able to show that we don't only need to treat atherectomy. We don't only need to treat the plaque. It's not just about getting the vessel open, but it's also about trying to prevent these patients from coming back with restenosis. And that patient that has to come back to the cath lab 6-7 times over a 10-year span, if we can keep him maybe from coming back after one treatment. We're now currently looking at the Limbo trial, which is a below-the-knee trial, which is similar to DANCE, except with this one we're doing the same thing. We're comparing atherectomy versus just balloon angioplasty. We're having 16 sites. We only have 3 sites enrolled right now. We're one of the 3 sites, one of the first enrollers in the country. We're looking at this population is for people that have rest pain or non-healing wounds or some sort of amputation is planned. So this is the worst of the worst legs that we're looking at because we think that by treating the inflammatory process, we can make a difference. So, thank you.